complications of renal transplant is many complications are there. Here we will be discussing PTDM and bone disorders. So around 15 to 20% of non-diabetic kidney transplant patients will develop PTDM by 6 months. Out of the over long term, it goes to 20 to 30%. In 2013 International Consensus Meeting, they have changed the term NODAT to PTDM. Why? Because NODAT excluded patients with undiagnosed pre-transplant diabetes. And PTDM, it includes all post-transplant diabetes first recognized after transplant, regardless of the pre-diabetic status pre-transplant, but it excludes transient post-transplant hyperglycemia in the first 6 weeks post-transplant. One second. It should be diagnosed once the patient on stable immunosuppression and stable graft function and in the absence of acute infection. HbA1c is not used in the first 3 months because of its false low value due to anemia and erythropoietin treatment and blood transfusion and all. So 2024 consensus guidelines, they don't recommend HbA1c to follow in the first 3 months. And also fasting glucose has got low sensitivity for diagnosing PTDM. So here the gold standard is the oral glucose tolerance test, which is to be used for diagnosing PTDM, and also for screening pre-transplant patients, it should be used. That is what 2024 International Consensus Guidelines says. Afternoon glucose monitoring should be used in early post-transplant period to identify patients who are at risk and who should receive oral glucose tolerance test. So this is after 6 weeks. After 6 weeks, we make the diagnosis of PTDM based on oral glucose tolerance test. And after 3 months, if the patient has crossed 3 months, we can include HbA1c. Otherwise, fasting and random glucose is used. Next. The risk factors for PTDM, there are non-modifiable risk factors like African American race and Hispanics. They are 20% more risk for developing PTDM, even with steroid withdrawal, because of their higher requirement for calcineurin inhibitor dosage. And also the age is one of the non-modifiable risk factor. 40 to 45 years is a threshold age for developing PTDM. And family history of diabetes in the first degree relatives and history of gestational diabetes and male recipient, male donor, deceased donor, history of acute rejection, and also HLA mismatches and genetic polymorphism. These are some non-modifiable risk factors. And potentially modifiable is a pre-transplant history of hepatitis C infection. It has got a 4 times more risk for PTDM because of the hepatitis C virus induced beta cell dysfunction and the liver dysfunction. Also cytomegalovirus infection pre-transplant. And the pre-transplant impaired glucose tolerance and impaired fasting glucose, they definitely goes into PTDM. So that should be identified by oral glucose tolerance test. And modifiable risk factors like patient recipients with obese. If the BMI is 25 to 30, there is 1.5-fold higher risk for developing PTDM. And this doubles by BMI more than 30. And also the post-transplant usage of immunosuppressive medications that we will be coming into. And vitamin D deficiency also high risk for PTDM onset. And the end-stage kidney disease due to polycystic kidney disease, because of the genetic association, they are also at high risk for PTDM. Next. So about immunosuppression, prednisolone is high risk. If the dose is more than 10 mg per day, 1.8-fold increased risk for PTDM. And as the dose increases, the risk is more. And in a study, they have found that 0.01 mg per kg per day increase in steroid dose, there is 5% increase in PTDM. CNI is, in that, TAC is 2 to 3 times more diabetogenic than cyclosporine because of its marked beta cell toxicity, calcineurin inhibition, and insulin hyposecretion. And the initial months, higher trough level is also associated with high risk for PTDM. Those on CNA, especially tacrolimus, by around 3 years, they have seen 10 to 25% of the patients develop PTDM. Direct study, a 2004 meta-analysis that showed that 10% higher risk with the TAC than cyclosporine. And ELITE study also showed the higher risk with the TAC dosage. And recent meta-analysis of 56 randomized control trial that demonstrated that less PTDM with a better overall graft survival in patients who had undergone CNI minimization and avoidance strategy using newer drugs. So what is the mechanism of immunosuppressant-related hyperglycemia? Insulin resistance is the main mechanism with glucocorticoids. Calcineurin inhibitors results in insulin hyposecretion. That we will be coming into detail in next slide. Next slide. The CNI-mediated pathogenesis in PTDM. The CNI goes and binds with the immunophilin, which in turn inhibits the calcineurin. So it prevents the dephosphorylation and nuclear translocation of the transcription factor NFAT. So what happens in the beta cells? In the beta cells, it results in expression of the key transcription factors for the beta cell survival will be reduced. So it results in apoptosis of the beta cells, and the reduced expression of the GLUT2 and glucokinase genes involved in and in mitochondrial oxygen consumption will be decreased. That results in secretory dysfunction of the beta cells. And in adipose tissue, less NFAT activity will reduce the recycling of the GLUT4 and subsequent glucose uptake. Muscle fibers, because of the blockage of NFAT, that the phenotype switch occurs from type 1 to type 2 fibers, that will be less insulin sensitive. This is the main pathogenic mechanism by CNI in PTDM. Next. So we should start screening pre-transplant itself with look for the risk factors which we already discussed. And if the patient is at risk, do a pre-transplant OGTT according to 2024 guidelines, and start lifestyle modification, weight reduction, and if patient is HCV positive, treat pre-transplant itself. In one study of 120 transplant recipients with diabetes, they have seen that 18% patients had impaired glucose tolerance on OGTT prior to transplant. And 35% who developed PTDM had impaired glucose tolerance prior to transplant. So here comes the importance of pre-transplant OGTT, especially in at-risk patients, and post-transplant monitor for the blood sugars closely in the early post-op period, including postprandial blood sugars should be monitored. Early insulin therapy for post-op hyperglycemia has reduced PTDM by 73% in some studies. And HbA1c can be used after 3 months post-transplant. If the HbA1c is more than 6, go for strict home blood sugar monitoring and HbA1c quarterly monitoring. And if the patient had a perioperative hyperglycemia, they are also at high risk for PTDM. They also need close monitoring. Next. So how to adjust the immunosuppression? Steroid minimization is the main immunosuppression adjustment we can do. That is, the dose was reduced to 5 mg. 5 mg. They have seen that the PTDM at 1 year was reduced from 55 to 34%. But steroid withdrawal is not recommended for PTDM management because of the higher risk of rejection episode. We know that once the patient goes into rejection, we will be using high dose pulse steroids and higher chance for further PTDM. And few studies have found that there is no significant difference between 5 mg prednisolone compared to complete steroid withdrawal. They have seen 5-year post-transplant PTDM incidence is equal in both the groups. And also, there is no control data on the effect of late withdrawal of low-dose steroids in patients with established PTM. So we should weigh for the risk for rejection if we withdraw the low-dose steroids. Next. So CNA, we should attempt dose reduction without increasing the risk of rejection. Changing from TAC to, even though TAC is more diabetogenic, changing from TAC to cyclosporine for PTDM management is not recommended. We should take into immunological assessment. And also the effect of tacrolimus on glucose will be reversible over the time. The dose might there is chance of PTDM reversal long term. And conversion to sirolimus may worsen insulin resistance. That also not recommended. Switching to long-acting formulation may help glycemia in some studies, but mixed results that needs further evaluation. Next. So how to choose the diabetic medications? In the immediate post-op period, go for, depending upon the glycemic status, go for insulin. If glycemic status is not bad, we can consider oral hypoglycemic agents. The safer one is DPP-4 inhibitors. And once the stable graft function is achieved after some time, we can start the patient on oral hypoglycemic agents. The preferred ones are GLP-1 receptor agonist or SGLT2 inhibitors. Metformin, because of the higher risk for lactic acidosis, not like in non-transplant patients, it is not preferred as the first line in transplant recipients. And pioglitazone, it has got interaction with the CNI, and also it increases the immunosuppression-related bone loss. So it is not preferred, and also it has got some edema risk. So it is not that preferred use with caution. And sulfonylureas, weighing the hypoglycemia risk, we can, if needed, additional medicine we can consider. Meglitinates can be tried for postprandial sugar control. Next. This is also same slide, choosing the glucose lowering agents, especially patients, SGLT2, especially patients with a heart failure. We prefer for SGLT2 inhibitor because of its cardiovascular benefits, and obese and patients with established atherosclerotic vascular disease, we can prefer for GLP-1 receptor agonist because of its renoprotective and cardioprotective benefits. And unstable patients with unstable graft function always prefer for insulin or DPP-4 inhibitors. Next. Few words about SGLT2 inhibitors. It is usually started once stable allograft function is achieved. Non-transplant population, their EMBARC outcome trial has shown reduction in CV events and all-cause mortality, but that is not tested in renal transplant recipients. And the glucose lowering effect is much less when the GFR goes below 30 to 45, but we can benefit by non-glycemic benefits like CV outcome and allograft survival. But even then, long-term data is not there with the SGLT2 inhibitors. And we should wait for the urinary and genital fungal infections. Next. GLP-1 receptor agonist, it has got benefits like it improves the glycemic control and less hypoglycemia risk, and it has got weight loss. It is renoprotective and cardioprotective, and this also same like SGLT2 inhibitors started once stable allograft function is achieved, and this has less interaction with TAC because it is eliminated by the proteolytic degradation, not by cytochrome P450 enzymes. But this decreases the gastric emptying, so food interaction with the TAC should be taken into consideration. And there are many studies which have come with the recent publications with the lower risk of MACE and all-cause mortality in transplant recipients, and GLP associated with the better graft and patient survival. But the risk is diabetic retinopathy and GI side effects. Here also, like SGLT2 inhibitors, long-term data is not there. Next. So GLP-1 receptor agonist has some role in reversing the TAC-mediated beta cell dysfunction. So what happens? The TAC inhibits the insulin secretion by suppressing the calcineurin NF-80 and reduces the calcium-dependent exocytosis. So when we are using GLP-1 receptor, this activation generates a cyclic AMP, and that will increase the calcium influx and overcomes some amount of TAC-induced beta cell dysfunction. Renal metabolism alteration can persist even with a successful renal transplantation. So this leads to cardiovascular and osteoporotic fracture risk. And so risk factor recognition and BMD assessment is important, and we should attempt for glucocorticoid minimization to avoid this. What are the factors related to renal transplant bone mineral disorder? Always we should look into the pre-transplant mineral bone status, and the modifiable factors post-transplant includes glucocorticoids. Glucocorticoids, it increases the osteoclastic activity and decreases the osteoblastic activity. So leads to increased bone resorption and reducing the bone formation. And also the hyperparathyroidism, which is persistent post-transplant, it leads to decreased bone formation and mineralization, leading to bone loss and fractures. And as the graft function deteriorates, there will be accumulation of FGF23, which decreases the active vitamin D. That also leads to decreased bone formation and mineralization. So, what are the alterations in minerals post-transplant? First, about the calcium. It is biphasic trend after renal transplant. Initially, we notice a decrease in calcium level that is due to rapid fall in the PTH level with a successful graft function. And later, it increases. That is because of the increased production of the active vitamin D by the healthier kidney and the persistent hyperparathyroidism. By around first year, end of first year, 25% of the patient can have a hypercalcemia that can lead to interstitial microcalcification and negative graft outcome. Vitamin D deficiency is noted by 3 months in 80% of the transplant recipients. This vitamin D deficiency leads to hypocalcemia, impairs the bone mineralization, and it can also affect the graft function, can increase the risk of acute cellular rejection because of its effect on T cells and the dendritic function. Phosphorus, severe hypophosphatemia is noted in the early post-transplant period in around 50% of the patients. By 1 year, almost 15% also will have a hypophosphatemia. This is due to better tubular sensitivity and the responsiveness to PTH and the FGF23 action post-transplant. Also, the drug CNI, which can induce tubular toxicity leading to phosphaturia. This hypophosphatemia can lead to impaired osteoblast genesis and early osteoblast apoptosis leading to osteoporosis. And immunosuppressants can also alter the minerals. Glucocorticoids induces the enzyme involved in vitamin D catabolism and increases the PTH and FGF23 level. CNI also inversely associated with the vitamin D level. Hyperparathyroidism, persistent hyperparathyroidism post-transplant, even though there is PTH decreases with good graft function within 1 year of post-transplant because of the involution of the parathyroid glands and the correction of metabolic abnormality, there can be 50% patients with a persistent hyperparathyroidism. This depends. This occurs in patients with a severe pre-transplant hyperparathyroidism and the longer the dialysis vintage also. And also the regression of the parathyroid hyperplasia, which happened pre-transplant, is slow due to low cell turnover and long lifespan of the parathyroid cells and the clonal growth of the gland, which will be less sensitive to the normal feedback mechanism, even though it happens post-transplant. And the clinical manifestations post-transplant hyperparathyroidism is usually primary hyperparathyroidism with an increase in PTH and increase in calcium and decrease in phosphorus. This leads to bone loss and increases the fracture risk and worsens the graft survival. A study has shown that PTH level more than 130 at 3 months post-transplant. They noticed 7.5-fold higher fracture risk at 5 years. So how to monitor for the biochemical parameters? So early and aggressive monitoring for the calcium and the phosphorus is needed at least weekly until it is stable. And the frequency of monitoring can be reduced later. Subsequent monitoring is almost like a CKD population. As the GFR deteriorates, the frequency can be increased for the vitamin D and calcium phosphorus PTH, alkaline phosphatase. Bone mineral density assessment is important. That is by DEXA scan, that is dual energy X-ray absorptiometry. 2017 Pedigo guidelines recommends BMD testing for all transplant recipients G1T to G5T. If the patient is on corticosteroids or has other risk factors for osteoporosis, and we think that the testing will alter the treatment, alter the therapy. So then they all should be offered BMD testing. But in 2009, Kedigo guidelines, they didn't suggest for BMD testing for G4T to G5T. So once we have a baseline BMD assessment around 3 months, then go for the correction of the biochemical parameters and stabilizing the biochemical parameters. That is the first and foremost thing to be done. And after that, you can repeat the DXA scan 6 to 12 months later. And if the fracture risk is high, and if the patient is not started on treatment, close monitoring of the BMD is needed at least yearly. And if the fracture risk is not that high, then you can increase the frequency of monitoring maybe every 2 years, and further stabilization, further increase the interval. If the patient is started on anti-osteoporotic pharmacotherapy, we need at least 1 year after a repeat DXA scan to assess the BMD status. So this is the T-score that we know. And also we can use high resolution peripheral quantitative CT that will quantify the volumetric assessment of the cortical and trabecular bone. Bone biopsy is ideally the gold standard, especially for low turnover bone disease, like adynamic bone disease. Before we initiate anti-resorptive therapy, ideally we should rule out adynamic bone disease because the biochemical testing will be inadequate. But this is not often performed and it is limited to research because it needs more expertise in making the diagnosis. And 2017 CKD MBD guidelines, they have given that consider bone biopsy to guide treatment in the first 12 months post-transplant, but this is not graded because of the lack of evidence. And so far, no guidelines mandate the need for bone biopsy to start treatment. And also, we don't have a sufficient data after 1 year. So this is an algorithmic approach how to approach the post-transplant bone disorder. Assess for the fracture risk and bone turnover from clinical, laboratory, and imaging assessment, BMD assessment, and then offer lifestyle measures, glucocorticoid dose minimization, and calcium vitamin D supplementation, and addressing the modified risk factors to be done for all patients. And if the patient is having a persistent hyperparathyroidism, hypophosphatemia, and vitamin D deficiency, then correct it and reassess the fracture risk after 6 to 12 months. If the patient doesn't have these alterations, then based on the fracture risk, if the fracture risk is high, look for the bone turnover status. And based on that, you can plan for active vitamin D analogs or anabolic agent, especially if the patient is having a low bone turnover. And if the bone turnover looks high or normal, anti-resorptive therapies, bisphosphonates or denosumab is preferred. If the fracture risk is low, no indication for anti-osteoporotic pharmacotherapy. Continue with the general measures. So this is general measures, and the steroid minimization. We should come down the steroid dose minimum of less than 7.5 milligram per day, because many studies has shown that fracture is high without and with steroids. They have shown that 1.7 versus 3.3%, and at 1 year it was without steroids it was 26% lower, and 3 years it was 70% lower risk for fractures in patients without steroids. So how to supplement vitamin D, calcium? Patients with hyperparathyroidism without hypercalcemia, we should supplement vitamin D and calcium. That will help in better preservation of the BMD and prevention of fractures. So this vitamin D addition along with the calcium, that will help in better calcium absorption, and keep a calcium intake around 1000 mg per day, and vitamin D level to be kept more than 30 nanogram per ml. And in patients with hyperparathyroidism, we need either calcium mimetics or parathyroidectomy, but the optimal management is pre-transplant. Even if we use calcium mimetics, there's no positive effect on the bone mineral density. And also the cinacalcet can reduce the TAC level. And if the patient is refractory to calcium mimetics, better go for surgery, parathyroidectomy. And there are retrospective studies, they have found that parathyroidectomy is better than cinacalcet, improving the allograft survival and all. It was 9 versus 33%. And using recombinant PTH, that is teriparatide and active vitamin D analogs in patients with a low bone turnover. This is osteoanabolic agent. It can be used in patients with a severe osteoporosis with evidence of a dynamic bone disease. It's given as a subcutaneous injection daily. But with completion of treatment of teriparatide, we have to continue with anti-resorptive therapy if bone turnover is expected to rebound. And this also, we don't have a long-term data in renal transplant recipients. And if there is no evidence of low bone turnover, we can treat the patient with anti-resorptive agents if the fracture risk is high. If you are suspicious, we need bone biopsy to rule out a dynamic bone disease. And bisphosphonates, how does it act? It accumulates at sites of active bone resorption, but there is a limitation with renal dysfunction. GFR more than 30, we should use it. And long-term effect on renal transplant is not available. Denosumab is a humanized monoclonal antibody against receptor activator of NF-κB ligand. It inhibits the osteoclast proliferation. And it is renally safe because it is not cleared through kidney. It can be given through any degree of graft dysfunction. So it is preferred over bisphosphonates. But the problem is discontinuation. It can result in rebound bone loss and fractures. So we should, once we stop denosumab, we should continue with the bisphosphonate therapy. And also patients on denosumab look for calcium level, chance for severe hypocalcemia. And how to follow up if the patient is started on an osteoporotic pharmacotherapy, anti-osteoporotic pharmacotherapy. We repeat the DXS 1 year later, and if the BMD is stable or better, still the patient is having a major non-BMD risk factor for fractures, like a patient is on continued on glucocorticoids more than 5 mg per day or other risk factors. Even if the T-score is better, you continue with the anti-osteoporotic pharmacotherapy. And if the T-score is osteopenic or osteoporotic at any of the skeletal site, then also we need to continue pharmacotherapy and with the remeasuring 1 year later. If the BMD decreasing or interim fragility fractures develops on treatment, then look for complaints and other causes, switch to other potent agents. Few words about post-transplant osteonecrosis. This is vascular necrosis. Just one slide only, sir. This is because of the direct damage to bone vasculature, mainly by the glucocorticoids. And the weight-bearing bones the long bones are usually affected. Femoral head is the most common site. And in transplant population, it is usually multifocal. In 50 to 70%, pain is the main presentation. Also, CNI can cause bone pain. This is because of the intraosseous vasoconstriction and hypertension. MRI will look edema and subclinical trauma will be shown. CCV can be added, and reduction in CNI is the treatment. So all transplant recipients should be evaluated for mineral bone disorder and monitored for ongoing bone loss. Initially focus on biochemical abnormalities associated with the bone mineral disorder. Reducing cumulative glucocorticoid exposure combined with calcium and vitamin D supplement alone will be sufficient in transplant to prevent bone loss after transplant. Anti-resorptive therapy should only be reserved for patients with high risk of fracture with a significant bone loss, despite optimal supportive therapy after ruling out a dynamic bone disease. And KDIGO points data are insufficient to guide treatment after first year post-transplant. So all what we have is within 1 year transplant. That is limited to